Okay, DAT folk. This is what I would like to do my action research project on, using the functional movement screen in a dance population, FMS in a dance population. So this presentation will look sort of similar to my first one that I did, but it will be way more in depth, I hope. Introduction: dance is a rigorous athletic activity and art form. Shout out 2012, it is. So a lot of dancers are athletes, right? They have that warrior mentality. I don't like that word warrior because I think that the media overuses that word, saying, hey, playing a football game is like going out to the front lines of Iraq and war. That is not what I'm trying to say here. I get very upset when people say that. So dancers have a warrior type like mentality that they don't want to be told to sit out. It is rigorous and an art form. They have to be strong, excuse me, proper biomechanics, and still be aesthetically pleasing to the crowd. I know I cannot dance very well, and I see some of the dances that our company puts on here, and I'm very impressed. Overuse and chronic injuries account for about 60 to 76% of all injuries. And you can see 1, 2, 3, 4 references there from the 80s all the way up until the late 2000s, 2010. And there are more research studies coming out about this. Overuse and chronic injuries. The majority of injuries I see in my patient population, which is dance, are from overuse, chronic in nature. So, dance company at MCLA. I teach at Massachusetts College of Liberal Arts. So, abbreviation MCLA. Our company here is very unique. It is student-led with about 85 members this fall. Typically the spring, they have a little fewer because more students do internships in the spring. Both male and female. They have an advisor who is an FPA, Fine and Performing Arts faculty member, and pretty much myself, since I'm with them all the time. I'm not an official advisor, if you will, but I'm with them more than their other advisor is. It's very unique because it is student-led. They have an e-board, so an executive board with 5 members, a vice president, 2 co-presidents, treasurer, secretary, and that it's open to anybody on campus. Some have had no dance training at all, and others have danced their entire life. So these students, they come in, all they have to do is participate in one dance, which are all choreographed by students, no faculty involvement at all, which I think is awesome. So I have patients, dancers, that the first time they've ever danced is right now in college, which is good and bad, right? It gets them moving, gets them physically active, but if they have dysfunction, right? If they have something else already going on, improper biomechanics, leads to injury, I think. Others that have danced their whole lives, they're usually the choreographers, they're the more advanced dancers in the company. They don't like telling me they're hurt, but they're getting better and better and better at that as they get more exposure to me. Also for our athletic training program, we utilize dance as a clinical site. I have 3 students assigned to me, and we have a clinic every afternoon for about 3 to 4 hours, and then on Sunday we go to dance rehearsals. So the unique thing about dance company is they could practice at any time throughout the day or night whenever they have space available. So some rehearsals might go from 10 till midnight. I'm not typically here from 10 till midnight. So last year and this year we have a dance clinic that is open typically 1 till 4, 1 till 5, depending on the day and depending on faculty meetings I have to go to, that any of the dancers can come in, get evaluated, we do rehab, we do anything that we need to do during that time, and then every Sunday for 3 hours we hang out with the dance company. We typically lead stretching, we do some different things with them, which is pretty unique for me, and I actually enjoy it. I didn't know if I would when I first accepted the job here, and I do. So epidemiological statistics on dance injuries. Majority of these injuries are to the foot and ankle. Garrick, Ojo, Fumetti, and Ronco. Cannot have easy names, can they? How come? Well, we're going to talk about this in the biomechanics section. Majority of these injuries to the foot and ankle are due to overuse. Lee Anderson, Nilsson, Gamboa, et al. So it makes sense to me that foot and ankle injuries happen in dance because something called turnout we'll go over. Also because just they don't wear footwear. As soon as they come to dance company on Sunday, they take off their shoes and leave them outside the dance studio. They just, I think, have some dysfunction going on, especially being a general student population, not your typical athletes. I have some patients here, dancers that weigh close to 350, 400 pounds, and they're trying to dance for the first couple times in their career, their life. That's different. That's very different than a typical dance major dancers that you think of. Yeah, we'll leave it at that. Epidemiological statistics. I had this chart in my last presentation. The epidemiology of foot and ankle injuries and overuse injuries. So these are all different studies, 1, 2, 3, 4, 5, 6 studies here that look at foot and ankle injuries in dance, and they look at the percentage of overuse injuries in dance. Now, not all of these gave overuse numbers, so therefore you see the NA. But about 43% of all dance injuries happen to the foot and ankle. That's a lot. That's almost half. My math isn't great, but I know that's almost half. Overuse injuries, 61% is overuse injury. That's ridiculous. Almost 3/4 of the injuries that we see in dance are overuse. Why? What are we doing wrong? What are they doing wrong? What is their body telling them? Something is not right here. Again, what does this mean? We know a high percentage of dance injuries are chronic overuse. How come? Dr. Nasipini, on his comments to me on my first go around at this little snippet we did, I guess you could call it, said a lot of people look at the pain, not the cause of pain. Athletic trainers, we're taught to do that. We're taught if your knee hurts, we put ice on it, put some cinnamon on it, good to go, right? Pain's gone away, pain decreased, we did our job. Well, why is that knee hurting? Is there a biomechanical issue? Probably. So causes of pain I listed below here, 4 different things that I think it could be. I don't know, we don't know. Research can't tell us this yet. Could it be biomechanical? Could it be muscular weakness? Could it be dysfunction? Yes. Dysfunction is the word that FMS loves, right? Could it be neurological deficit? We just do not know. We have research out there on neuromuscular resetting, mirroring to a point, muscular weakness. There's a ton of research on muscular weakness, isokinetic devices. What does it tell you? Not a whole lot. I did my thesis on it. What did it tell me? You're going to pull your hamstring the older you get, and about the last 15 degrees of an eccentric motion. So if you're old and running fast, probably going to pull your hamstring. 2 years of research, right? I don't want to look at the muscular weakness part. I want to look at the dysfunction, biomechanical issue. The neurological deficit, I think, is something else that we could look at. Probably not while I'm in the DAT, though. I'll elaborate on that in a minute. So some biomechanics, lack of clear terms across dance profession, both dancers and healthcare professionals. Ahonen, 2008. There is a disconnect between dancers, between healthcare professionals that treat dancers, and between everybody involved in the circle, in the loop. It's kind of like athletic training. When I lived down south, we called different exercises different names than we do up north. It's the same exact exercise, but why do we change the name? It's like the soda and pop thing, right? If you're from one area of New York State, you say soda. If you're from another, you say pop. Well, makes no sense. So we're lacking clear terms in research. So some of our research is skewed. Ballet dancers with proper positioning, ballet. I am not a ballet dancer. We actually, at our dance company here, don't do a whole lot of traditional ballet pieces with ballet music and everything. We use modern music. Excuse me. We might use a song by Adele, and that choreographer may incorporate ballet moves into their dance, but we're not traditionally doing a ballet dance, which is a little unique, and I kind of like it because I don't think I would like that older style music. Turnout, which we'll talk about here in a second, and I copied this quote, typed this quote from Ahonen again. When used in dance, the foot and ankle must provide a perfect platform for any movement. Unfortunately, when there is a dysfunction, the system can stop working and cause injury or pain. Yes, when I started working dance, I didn't know what to expect. The only injuries I really see are foot, ankle, and knee, patella tendon. Unfortunately, when there is a dysfunction, this system can stop working and cause injury or pain. Yes, what is the dysfunction? Where is it coming from? Do they have something going on in the knee that's causing their foot and ankle to hurt? Do they have something in their shoulder that's causing their foot, knee, ankle to hurt? Where is their dysfunction? That's why I think the FMS will work well. This is a picture I took off of Google of the plie position. Ballet dancers require plie position. It's a very abnormal position, as you can see. This Russell et al. 2008. He did a clinical anatomy of the foot and ankle for dance. And it's pretty much a general overview of the anatomy of the foot and ankle, and it's an okay article for anatomy-wise, but he really didn't incorporate a whole lot of dance movements into it, and that's what the article was very frustrating. I thought it would be a little better, honestly, and I get a little frustrated by that. So as you can see, there's 5 different poses here, positions. So first position through 5th position. If you ask a trained dancer to get into 3rd position, they could do this automatically. So this is a little kid, I don't know, 6, 7 years old probably, that can get into these positions. If I were to try these, I would be hurting right now. As you can see at my next bullet point here, flexor hallucis issues arise from this, or can arise from this. I'll hone it again. And I've seen that. I've seen a lot of, I don't want to call them itises. I don't want to necessarily classify it as an itis or any type of injury per se, diagnose it. But I have seen tightness, pain coming from that. So, real world application, yes. Turnout. I got a picture on the next slide here coming up. So it's a fundamental framework of ballet and dance technique. Refers to the external rotation of the lower limbs with the feet at usually 180 degrees, at most 180 degrees. Ideally, this would come from the hips, not the knees, not the ankles. Your hips. So your hips externally rotate. They take the brunt of the 180 degrees. Obviously, your knees will have some torsion and your ankles will have some movement. But your hips should not be moving 30 degrees and your knees moving the 120. That is not going to be successful. That is going to cause dysfunction, right? So in parentheses here, I wrote novice versus expert. In my dance company, that's what we see. And I think that's why I see some injuries in dance. The novice dancers, the first timers, the ones that are doing it because it's fun in college and they actually do enjoy it and they learn and they get better, are typically the ones I get to see first. And I think that the turnout has something to do with that. Next bullet point here, I say compensatory strategies such as anterior pelvic tilt and pronation. Well, that's a dysfunction, right? Don't we look for things like that on the FMS? I believe we do. That's why I think the FMS would be awesome in dance population. Turnout, picture, Google. Thank you, Google. So as you can see, the feet this is about 136-degree arc from mid second toe to the second toe. That to me would hurt. Now, I'm Polish, right? So I stand like this. This is how Polacks stand. That's what my dad always says. Next summer, when you guys see me walk, this is how I walk. I walk like a duck. So this is classic turnout phase, or turnout motion. This would hurt. So you're doing this with a dance. You're in 3 dances, and you have to do this for 2 hours a day, 4 days a week, for 16 weeks until the show, 15 weeks until the show. You're already having a dysfunction somewhere else in your body. So then your knee starts hurting, or your ankle starts hurting. You don't want to tell anybody because you want to keep dancing, right? 12, 13 weeks go by, next thing you know, you can't even get out of bed to walk across campus because your knee hurts so bad, or your shin, or whatever it might be. This, I think, is why we're getting the dance injuries that we see. Now, I did not include positional release in this. I still want to look at positional release. I still want to use that. But is that enough to make me an advanced practitioner? Maybe. Probably not. Excuse me again. I will get results with it, yes. I just did it. We had a dancer come in Monday. 6 out of 10 on pain on her medial side of her knee. No mechanism that she could remember. I did 2 sets of positional release on 2 tender points. She left with a 0 out of 10 for pain. She went to rehearsal that night, came back the next day, told me she has no pain. That's awesome. So again, why FMS? I think I've said this multiple times, why FMS throughout this presentation. FMS screens movement patterns that may decrease the chance of injury later. So why would we not want to use this for dance? Let's cook that out, right? Easy use for clinicians. It is. It's really easy to use. Once you train yourself in it, watch the videos, which I'll talk about here in a second, it's easy to use. We'd use it for our ATEP students too. We have undergraduate research here. We have undergraduate research conferences and all that. And a lot of the students are very interested in what I'm doing in the DAT. I would like to include them in my study. I would like to have them help me out as a, maybe a 1-credit research special topics class that they can do. They get credit for it, and they produce something at the end, and they have to present on it at our research conference. I think that's an awesome idea. So dance and FMS. FMS has not been studied in the dance population. It's been basketball, it's been football, it has not been dance. Athletic trainers and performing arts, we're an emerging practice setting, right? If you look at the NATA, we're an emerging practice setting. If you go on the NATA Career Center, there are numerous 6 to 8 to 10 job opportunities for dance athletic training at universities through their FPA, Fine and Performing Arts Department. That's very unique. I think that's a trend we're going to see continuing to grow. So we need outcomes in this population as well as the traditional athletic population. It fits into the time frame for the DAT program. 2 years, year and a half almost, right? We're almost done. Year and 3/4 past midterms now. We got to be done with this. That's a short window to do this research in. But it can also turn into a long-term project, which I'll talk about next. We need to develop new knowledge in a specific population that could be translated across to other populations. So some of the studies I cite, Plisky, talking about football players and predictive scores of 14 or less, you're at a greater risk of injuring yourself throughout the season. Can we really translate that into dance? Maybe. I don't know. Excuse me, my cough is coming back. FMS and my institution, MCLA. Equipment, we already have it. We actually have 3 FMS units, packages, whatever you want to call them, in our storage unit right now. My attending clinician, Pete, did his dissertation using FMS and Y balance with corrective exercise. he was going to use the dance population, and then at the last second he had to change something in his proposal and ended up using our NCAA athletics to do his dissertation instead of dance, which is great for me because I'd like to do FMS, and he's all about this. He likes doing this stuff. He's an expert in this. I consider himself an expert. We have similar ideas and goals. Our ideas and goals are mirroring. He sees me doing TMR, total motion release, and he's like, wow, I did this at Rocky Mountain in my PhD. We did about a day of it. I didn't really do it in a clinic-based setting before because his PhD was research-based and he had no patient care attached to it. He's like, I think there's something to this. I want to do a research study on this. I said, Pete, let's do this. When I get done with my PhD, my DAT, not PhD, right? DAT, why don't we collaborate on a project with the mirroring, with TMR, with FMS, comparing TMR, different ideas like that. We have very similar ideas and goals. Chance to meet the godfathers of FMS on committee, hopefully, maybe. Not Jim May, sorry, godfather. Plisky, Cook, Voigt, all these guys were on his dissertation committee. Actually, Plisky was the chair of Pete's dissertation committee. That would be awesome if I could get Plisky in here and with us to help out with my study, even the DAT. I have up to 85 patients that could be included in the study as well already. Free access to them, right? Some action research questions I think could be answered. Can we use FMS to screen a dance population to track injury over time? That's what I would like to do. So Dr. Nasipini had emailed me some comments about my other one, like I said, and I like the idea to use FMS to predict the injuries. So can we validate a score of less than 14 on the FMS increases the chance of injury? This Kiesel et al. Article is the NFL one I'll talk about here in a second. I think we can, given the short amount of time in the DAT. I think that studying them, hell, even starting the spring into next spring, so you study them for 2 semesters, 3 semesters maybe, and look at their scores, and did they get hurt? Is it a chronic injury? Is it an overuse injury? Now, the thing that I don't know what I would want to do we give them interventions? That's more SFMA, right? If they have pain, we give them intervention. But would we give them a corrective exercise like my attending clinician did? Or would we just kind of do these and see how they go over time? Maybe remeasure them. These are some questions that haven't been answered yet in my head. 1, I'm still diving more into the literature. 2, I don't know what's best. Can using the FMS to screen the specific population decrease the amount of overuse chronic injury? Yep. So now do we fix them or just track them? Which came first, the chicken or the egg? So, Dr. Nasipini wrote my comment. He said, build a need before you start to confuse the issue with treatment. So do we need to treat these people? Do we have a need in this population? I think we do, especially if you look at NATA jobs that are coming out. We need more outcomes in this population. Just how do we do that properly? So I think the FMS in athletic training, in dance medicine as we call it here at MCLA, will work well at our setting. Outcomes measures, obviously I would use the FMS score, the DPAS scores if they get injured, a numerical pain scale, the probability of suffering an injury. There's some statistics here that you can look at, the ROC curve, the ROC curves and whatnot. Any other outcome measures, I was sitting there thinking today when I was finishing my presentation to think of anything else I could put in for outcome measures. I don't know of any right now. I guess demographics. I looked at some other studies that had anthropometrics in it, such as body fat, using skin calipers and all that stuff, and I don't necessarily know if there's a need for that yet. Could we correlate increased body fat and FMS scores? Maybe. I don't know. That's, again, need to get more into the research. So my seminal article is Kiesel et al. 2007. This title of the article, it's up on TaskStream, or will be. Can serious injury in professional football be predicted by preseason FMS functional movement screen, right? They examined one NFL team, 46 players, found players who were injured, scored a 14 or less on FMS based upon a 2x2 contingency table. So sensitivity, specificity, they break these down into groups. Did they get injured? Yes. Did they have a score of less than 14 on FMS? Yes. Well, there you go. So they found 13 players suffered serious injury. Serious injury in this study, the operational definition was that they landed on injured reserve, so they were done for the season. So that's something I might have to define as well. What is a serious injury? What are these definitions? Players with a score of 14 or less have the greatest chance of injury. We need to examine other populations, though. Can this correlate, translate to dance? How will I become well-versed in the FMS? Included in my plan of advanced practice, I have attending clinician as an expert, by far an expert. The Northeast seminars videos. Seminar if possible, if the right location, time, money, all that come up. But I think by watching the videos and having a clinician who is an expert in this is a great start. So I have some references up here. While I'm going through these, again, I want to thank you for watching the presentation. Please give me good constructive comments. To me, this is a work in progress because, yeah, it's still October. We're still diving into the research, trying to find more literature. What do we actually want to study? So this presentation will probably change, and I understand that, and it should change to meet the needs of what my question is. I think the FMS will work in my setting, and I think that I do have questions that I don't know what to do with yet. That's where I would like more feedback from both Dr. Nisipany and Sieg Miller, but all my classmates as well. Again, thank you.